Hello, and welcome back to the Sleep Lab tonight. Before you settle into whatever position your body has already, quietly, chosen without asking your permission, we are going to look closely at something almost nobody thinks about, even though it happens every single night of every single life. The position your body takes the moment you fall asleep is not a small, meaningless detail. It shapes how your brain clears waste while you rest, how your spine holds itself for 7 or 8 hours without you supervising it, how acid moves or doesn't move inside your stomach, how much oxygen makes it through your airway, and, in ways doctors have only recently begun to fully map, how your entire circulatory and lymphatic systems behave while your conscious mind is somewhere else entirely. Most of us fell into our current sleep position sometime in early childhood and never questioned it again, treating it the way we treat our handwriting or the way we tie our shoes, simply the way things have always been done, unexamined and unchosen. Tonight, gently, without any pressure to change anything about yourself right away, we are going to examine what medical science actually knows about the position your body rests in each night, why it matters more than almost anyone tells you, and what small, sustainable adjustments might genuinely serve you better, long after tonight's episode has ended and you've drifted off yourself. It's worth being honest, before we begin, about why this particular topic tends to receive so little serious attention compared to other areas of sleep science. Sleep duration gets discussed constantly, sleep quality has become a familiar wellness buzzword, and even sleep environment, things like room temperature and mattress choice, receives regular coverage across health media. Sleep position, by comparison, tends to be treated almost like a personal quirk rather than a genuine variable worth medical curiosity, perhaps because it feels too automatic, too unconsciously chosen, to seem like something science could meaningfully study or influence. Yet as we're about to see across the next 13 facts, researchers across neurology, cardiology, gastroenterology, obstetrics, dermatology, and sleep medicine have each, independently, found genuinely measurable consequences tied to something as seemingly trivial as which way your body happens to be facing when consciousness lets go each night. So if this kind of quiet exploration is useful to you, a like, a subscribe, or a thought left below helps this small lab keep its lights on for other sleepy minds finding their way here. But for now, there is nothing you need to do except notice, without judgment, exactly how your body is resting right at this moment. Let's begin. For decades, one of the deepest mysteries in neuroscience was a simple, nagging question: where does the brain's metabolic waste actually go? Every organ in the body relies on some kind of drainage system to clear away the byproducts of its own activity, yet the brain, protected behind the blood-brain barrier, seemed to lack the conventional lymphatic vessels that perform this job everywhere else in the body. The answer, discovered relatively recently and now called the glymphatic system, turned out to be a network that becomes dramatically more active during sleep, using cerebrospinal fluid to physically flush metabolic waste, including a protein called beta-amyloid strongly associated with Alzheimer's disease, out of brain tissue and into the bloodstream for eventual disposal. In 2015, researchers at Stony Brook University conducted an experiment that quietly reshaped how sleep scientists think about something as ordinary as which way you happen to be facing when you drift off. Using rodent models and specialized imaging, the team compared glymphatic clearance efficiency across 3 positions: lying on the back, lying on the stomach, and lying on the side, and found that clearance was significantly more efficient in the lateral, side sleeping position than in either of the other 2. The difference was not small. Side sleeping animals cleared measurably more waste, including the specific proteins linked to neurodegenerative disease, than animals sleeping on their backs or stomachs during the same observation window. While this research was conducted in animal models and researchers are careful to note that translating findings directly to humans requires caution, the study offered one of the first concrete, physiologically grounded explanations for something long suspected anecdotally, that how you position your body at night may influence, in a very literal, mechanical sense, how efficiently your brain performs its own overnight maintenance. This single finding has quietly reshaped conversations in sleep medicine, moving sleep position from a matter of simple comfort preference into a genuine area of active neurological research. The mechanics behind glymphatic clearance are worth understanding a little more closely, because they help explain why body position would plausibly matter at all for something happening deep inside the skull. Cerebrospinal fluid, the clear liquid that surrounds and cushions the brain, flows through specific channels alongside blood vessels within brain tissue, and researchers believe this flow is influenced by the same basic physics that govern fluid movement anywhere else in the body, including the effects of gravity and the relative position of different structures within the skull and upper spine. In the lateral, side-lying position, researchers hypothesize that the geometry of the brain and its surrounding fluid channels allows for less resistance and more effective bulk flow of cerebrospinal fluid, whereas the back and stomach positions may create subtly less favorable angles for the same fluid movement, though the precise anatomical explanation remains an active area of ongoing investigation. What makes this research particularly compelling to sleep scientists is the timing of its discovery. Glymphatic clearance was found to be dramatically more active during sleep than during wakefulness in the very same 2015 wave of research, meaning the position study didn't just add an interesting side note to existing knowledge, it arrived at almost the exact moment researchers were first beginning to understand that sleep itself might serve this specific, previously unrecognized cleaning function at all, giving the position findings an unusually prominent place in the broader story of how this entire field of research unfolded. Among all the specific sleep position recommendations in modern medicine, few are as consistently and firmly emphasized as the guidance given to pregnant women, particularly as pregnancy progresses into its later stages. The reasoning traces back to basic circulatory anatomy. A large vein called the inferior vena cava, responsible for returning blood from the lower body back to the heart, runs along the right side of the spine. As a pregnancy advances and the uterus grows substantially in size and weight, lying flat on the back can allow that growing weight to press directly against this major vein, meaningfully reducing blood flow back to the heart and, in turn, reducing blood flow onward to the placenta and the developing baby. Lying on the left side, by contrast, keeps the growing uterus off this critical vein, allowing blood to circulate more freely and, according to research on placental blood flow, improving oxygen and nutrient delivery to the fetus compared to the supine position. This is why obstetricians so consistently recommend left-side sleeping, particularly from the second trimester onward, and why so many pregnancy pillows on the market are specifically shaped to help maintain that particular position throughout an entire night, when unconscious repositioning would otherwise happen dozens of times regardless of any daytime intention. Beyond circulation alone, left-side sleeping during pregnancy has also been associated with improved kidney function, since this position is believed to help the kidneys more efficiently eliminate waste products and reduce fluid retention, a common source of swelling in the hands, feet, and ankles during later pregnancy. It's a striking example of how a piece of medical advice that sounds almost like folk wisdom, sleep on your left side, actually rests on a fairly precise, well-documented piece of circulatory anatomy, one your obstetrician likely mentioned briefly during a routine appointment without ever fully explaining the vascular mechanics quietly sitting underneath that simple, practical instruction. It's worth adding some reassurance alongside this fact, because obstetric guidance about sleep position is sometimes communicated in a way that leaves expectant parents feeling anxious about every single position they happen to wake up in, rather than understanding the actual, more forgiving nature of the underlying advice. Doctors specializing in maternal-fetal medicine consistently emphasize that the recommendation to favor the left side applies primarily to the position a person deliberately settles into when first going to sleep, and that waking up on the back or right side, which happens to nearly everyone at some point during a full night given how much natural repositioning occurs, is not considered a cause for alarm or a sign that anything has gone wrong. Many pregnancy-specific pillows are designed less to lock a person rigidly into one single position for 8 consecutive hours, which would be neither realistic nor necessary, and more to gently encourage falling asleep on the left side while also providing enough general comfort and support that the overall proportion of time spent off the back throughout the night increases naturally, without requiring constant conscious vigilance from an already exhausted expectant parent managing countless other physical changes during pregnancy. If you have ever woken in the middle of the night with a burning sensation rising up through your chest, the side you happen to be lying on may have played a far larger role than you realized. Researchers studying gastroesophageal reflux disease, more commonly known as GERD, have found a consistent and somewhat surprising asymmetry between the body's two sides when it comes to how easily stomach acid escapes upward into the esophagus during sleep. The stomach itself is not centered in the body but sits slightly toward the left side, with the junction connecting the esophagus to the stomach positioned in a way that, when a person lies on their left side, sits above the pool of stomach contents, using gravity to help keep acid down where it belongs. When a person lies on their right side instead, that same junction ends up positioned below the level of pooled stomach acid, making it considerably easier for acid to slip upward past the lower esophageal sphincter and into the esophagus, producing the burning discomfort commonly experienced as heartburn. Multiple controlled studies using pH monitoring equipment inserted into the esophagus overnight have confirmed this pattern directly, finding measurably more acid exposure time in participants sleeping on their right side compared to their left, across both people with diagnosed GERD and people without any formal reflux diagnosis at all. This is precisely why gastroenterologists frequently recommend left-side sleeping as a simple, drug-free first step for patients struggling with nighttime reflux symptoms, often alongside more familiar advice like avoiding large meals close to bedtime and slightly elevating the head of the bed. It's a small, almost mechanical detail, literally just a matter of which shoulder happens to be pressed into the mattress, yet it appears capable of measurably shifting how much acid actually reaches the esophagus during the exact hours when a person is least equipped to notice or respond to the discomfort building inside them. Researchers exploring this asymmetry have also examined how quickly the stomach itself empties depending on sleep position, adding another layer to why the left side appears consistently favorable for digestive comfort overnight. Because of the stomach's natural anatomical curve and the position of the pylorus, the valve connecting the stomach to the small intestine, lying on the left side, appears to allow gravity to assist gastric emptying more efficiently than lying on the right side, where the pylorus ends up positioned in a way that can actually slow the movement of stomach contents onward into the digestive tract. Slower gastric emptying means stomach contents, including acid, remain in the stomach longer, which researchers believe compounds the separate mechanical disadvantage already created by right-side sleeping's less favorable positioning of the esophageal junction. Together, these two effects, slower emptying and a less protective valve position, help explain why the difference between left and right-side sleeping shows up so consistently and measurably across multiple independent studies using different research methods, rather than being a subtle effect only detectable under unusually controlled laboratory conditions. Gastroenterologists often pair this positional guidance with a broader, practical set of recommendations for patients dealing with nighttime reflux, since sleep position tends to work best as one part of a coordinated approach rather than a solitary fix. Elevating the entire upper body, rather than simply stacking extra pillows under the head alone, which can actually worsen symptoms by bending the body at the waist and increasing abdominal pressure, is generally recommended through either a wedge pillow or an adjustable bed base that raises the torso as a single, gently sloped unit. Timing meals earlier in the evening, allowing at least a few hours for stomach contents to begin moving through the digestive tract before lying down, complements the left-side sleeping recommendation by simply reducing the total volume of material available to reflux upward in the first place, regardless of which side a person ultimately favors once they do fall asleep. Of all the sleep positions studied in modern medicine, none has received as much focused clinical attention as the supine position, simply lying flat on the back, largely because of its well-documented relationship to snoring and obstructive sleep apnea. When a person lies flat on their back, gravity works against the airway in a very direct, mechanical way. The tongue, soft palate, and surrounding soft tissue at the back of the throat are all pulled downward and backward by gravity toward the rear wall of the throat, narrowing the airway and, in many people, producing the vibration of soft tissue that generates the sound of snoring. In people with obstructive sleep apnea, this same gravitational effect can be severe enough to cause a temporary but complete airway collapse, briefly stopping breathing entirely until the brain, sensing rising carbon dioxide levels, triggers a partial arousal from sleep just long enough to reopen the airway, often without the sleeper ever becoming consciously aware it happened. Sleep clinics studying this phenomenon have identified a specific, well-recognized subgroup of patients called positional sleep apnea sufferers, whose breathing disruptions occur predominantly or almost exclusively while sleeping on their backs, with apnea events dropping dramatically, sometimes by more than half, simply by shifting to a side-sleeping position for the remainder of the night. This finding has become clinically significant enough that an entire category of medical treatment, called positional therapy, has been developed specifically around preventing patients from rolling onto their backs during sleep, ranging from simple foam wedges and specially designed pillows to modern wearable devices that gently vibrate the moment a sensor detects the wearer has rolled onto their back, nudging them back toward their side without ever fully waking them. For people who snore heavily or have been told by a partner that their breathing sounds concerning overnight, the single anatomical fact that lying flat on the back allows gravity to work directly against an open airway often represents one of the simplest, most immediately actionable pieces of information available, long before more involved interventions like a CPAP machine ever need to enter the conversation. Sleep clinics have also developed a useful clinical shorthand for identifying which patients are most likely to benefit substantially from positional therapy versus those who need more comprehensive treatment regardless of position. During an overnight diagnostic sleep study, technicians carefully record not only how many apnea events occur, but exactly which position the patient was in during each individual event, building a detailed positional breakdown that can reveal a dramatic difference between back sleeping severity and side sleeping severity in some patients, while showing relatively little positional variation in others whose apnea is driven more by factors like significant airway anatomy differences or excess tissue that obstructs breathing regardless of gravity's influence. This distinction matters enormously for treatment planning, because patients whose sleep study clearly shows apnea concentrated almost entirely during back sleeping are often excellent candidates for the simpler, less intensive positional interventions we'll discuss further later in tonight's episode, while patients showing significant apnea across all positions typically require more comprehensive treatment approaches, making this careful positional analysis one of the most clinically useful pieces of information a diagnostic sleep study can actually provide. Stomach sleeping, medically referred to as the prone position, occupies an unusual, somewhat contradictory place in sleep medicine, because it genuinely does offer one specific, measurable benefit while simultaneously carrying one of the more consistently documented downsides of any common sleep position. On the benefit side, lying face down does tend to keep the airway relatively open, since gravity is no longer pulling the tongue and soft palate backward into the throat the way it does in the supine position, which is part of why some people who snore heavily on their backs find noticeable relief when sleeping on their stomach instead. However, this benefit comes attached to a fairly significant physical cost concentrated almost entirely in the neck and spine. To breathe comfortably while lying face down, the head must be turned sharply to one side for the entire duration of sleep, placing the cervical spine in a rotated position it is not well designed to sustain for 7 or 8 consecutive hours. Physical therapists and orthopedic specialists who treat chronic neck pain report stomach sleeping as one of the most frequently identified contributing factors in patients presenting with persistent morning neck stiffness, tension headaches, and, in some cases, nerve irritation running down into the shoulder and arm. The problem extends beyond the neck alone. Because the prone position keeps the spine's natural curve flattened against the mattress in an unnatural way, and because most of the body's weight in this position rests on the abdomen and rib cage rather than being distributed more evenly the way it is inside or back sleeping, stomach sleepers frequently report lower back discomfort as well, particularly on softer mattresses that allow the midsection to sink further than the extremities. For the relatively small percentage of committed stomach sleepers who find this position essential for comfortable breathing or difficult to change after a lifetime of habit, sleep specialists generally recommend using an extremely thin pillow, or no pillow at all beneath the head, along with a slightly firmer pillow placed under the pelvis, to help reduce some of the rotational strain on both the neck and lower spine throughout the night. There is a related consideration specific to stomach sleeping that dermatologists and respiratory therapists both mention independently for different reasons. This position places sustained direct pressure on the chest and rib cage for the entire night, which can, in some individuals, subtly restrict full, deep breathing compared to positions that leave the chest unobstructed, particularly for people with any pre-existing respiratory limitation or for pregnant individuals in earlier trimesters, who may not yet need to fully abandon this position but should be aware of the added chest pressure it introduces. For infants specifically, stomach sleeping carries an entirely different and far more serious consideration, having been strongly linked in extensive pediatric research to a significantly elevated risk of sudden infant death syndrome, which is precisely why pediatric guidelines from organizations like the American Academy of Pediatrics have, for decades now, firmly and consistently recommended placing healthy infants on their backs for every single sleep, a public health campaign that has been credited with a dramatic, well-documented reduction in infant mortality since it was first widely adopted. This particular guidance stands as one of the clearest, most consequential examples in all of sleep medicine of how profoundly sleep position can matter, at every single stage of life, in ways that go far beyond simple comfort. For adults navigating a strong lifelong preference for stomach sleeping who find themselves unable to sleep comfortably any other way, sleep specialists generally recommend a gradual transitional approach rather than an abrupt switch, since attempting to eliminate a deeply ingrained position overnight often leads to frustration and poor sleep in the short term, undermining the very rest the change was meant to protect. A commonly suggested first step involves practicing a modified, less extreme version of stomach sleeping, using a body pillow positioned diagonally to allow the torso to rest at a slight angle rather than fully flat, which reduces some of the chest compression and neck rotation strain of full prone sleeping while still offering much of the same underlying sense of comfort and security many committed stomach sleepers describe as difficult to replicate any other way. Across large-scale surveys of sleep habits conducted in multiple countries, one position consistently emerges as the most commonly reported among adults: the fetal position, lying on the side with the knees drawn up toward the chest to varying degrees. Researchers studying sleep posture preferences have offered several overlapping explanations for why this particular position dominates so consistently across cultures and age groups. From a purely mechanical standpoint, the fetal position distributes body weight relatively evenly across a wide surface area, reduces pressure on any single point of the spine, and allows the body's largest muscle groups to relax fully without needing to actively hold any part of the body in a strained or unsupported position. There also appears to be a psychological dimension to the position's popularity, one that researchers studying sleep behavior have found genuinely compelling. A widely cited study conducted by sleep researcher Chris Idzikowski, surveying over 1,000 participants about both their preferred sleep position and their self-reported personality traits, found the fetal position to be reported by roughly 40% of participants, making it by a considerable margin the single most common sleeping posture recorded. Idzikowski and other researchers exploring this area have speculated, with appropriate caution about drawing overly firm conclusions from correlational personality data, that the position's curled, self-protective shape may echo something instinctively soothing about the physical posture of the womb itself, offering a subtle, unconscious sense of security that makes it easier for the nervous system to fully release into sleep. From a purely medical standpoint, the fetal position, particularly a gently curled rather than sharply curled version, tends to be reasonably well tolerated by the spine, and importantly shares the same airway protective advantages associated with side sleeping more broadly, avoiding the gravitational airway narrowing that affects back sleepers while sidestepping the neck and spine strain more commonly associated with sleeping fully on the stomach. Idzikowski's original survey research went further than simply ranking position popularity, also cataloging several other commonly observed positions and their relative prevalence, offering a genuinely interesting map of how varied human sleep posture actually is despite how rarely most of us think to compare notes with anyone else about it. The log position, lying on the side with the arms held relatively straight down against the body rather than curled toward the chest, was reported by roughly 15% of participants. The Yerner position, similar to the log but with the arms extended forward, away from the body, accounted for another meaningful portion of respondents. Soldier position, lying flat on the back with arms held straight at the sides, and starfish position, lying on the back with arms raised up near the head, each represented smaller but still notable percentages, while full stomach sleeping, sometimes called the freefall position when the arms are wrapped around a pillow, was reported as the least common overall. Beyond simple curiosity value, researchers studying this range of positions have noted that most people are not rigidly locked into a single category throughout an entire night, often beginning in one position before drifting through several others as natural repositioning occurs, meaning most of us are better described as favoring a particular starting position and a loose cluster of comfortable variations, rather than sleeping in one single fixed posture from the moment we close our eyes until the moment we wake. Cultural context also appears to shape sleep position preference more than many people realize, adding an interesting layer beyond pure biomechanics or psychology. Some cross-cultural sleep research has found modest but consistent variation in reported sleep position preferences across different countries and cultural contexts, likely influenced by factors as varied as typical bedding and mattress firmness in a given region, traditional sleeping arrangements involving shared beds or floor mats rather than individual mattresses, and even climate, since warmer regions may favor positions that expose more skin surface for cooling while colder regions may favor more curled, heat-conserving postures like the fetal position. This cultural dimension serves as a useful reminder that sleep position, while shaped by real biomechanics and genuine physiological consequences as we've discussed throughout tonight's episode, is never entirely separate from the broader environment, habits, and traditions a person happens to grow up within, making it a genuinely rich intersection of biology, psychology, and culture all quietly expressing themselves through something as ordinary as how a person happens to be lying down each night. Orthopedic specialists and physical therapists who study sleep-related musculoskeletal pain consistently emphasize a detail easy to overlook: the spine does not get a full night off simply because the rest of the body has gone still. Throughout sleep, the spine's natural alignment, or misalignment, continues to influence muscle tension, nerve pressure, and joint stress for the entire duration of the night, meaning a poorly supported sleeping posture can quietly undo much of the benefit that rest is supposed to provide in the first place. In a properly aligned side sleeping position, the spine should form a relatively straight, neutral line from the base of the neck down through the lower back, which typically requires a pillow thick enough to fill the gap between the shoulder and the head without tilting the neck too far upward or allowing it to droop downward toward the mattress. Many people unconsciously choose a pillow based purely on softness or personal comfort preference developed in childhood, without ever considering whether its thickness actually matches their individual shoulder width and mattress firmness, a mismatch that can leave the neck subtly misaligned for years without the sleeper ever connecting their chronic morning stiffness to something as simple as pillow height. Back sleepers face a related but distinct challenge, since the lower back's natural curve tends to leave a noticeable gap between the spine and the mattress that, left unsupported, can allow the lower back muscles to remain subtly engaged and tense throughout the night rather than fully releasing, which is why many sleep specialists recommend a small pillow placed beneath the knees for back sleepers specifically, since slightly bending the knees helps flatten that gap and allows the lower back to rest in a more genuinely relaxed position. These adjustments sound almost too simple to matter, yet physical therapists treating chronic morning back and neck pain report that pillow height and positioning support are among the most commonly overlooked, and most easily correctable, contributors to complaints patients often assume require far more complicated medical intervention to resolve. Mattress firmness interacts with all of this in ways that are frequently underappreciated, since pillow support alone cannot fully compensate for a mattress that either fails to support the spine's natural curves or, in the opposite direction, refuses to allow the shoulders and hips to sink in enough to keep the spine level while side sleeping. Sleep researchers and orthopedic specialists generally describe the ideal mattress firmness as a genuinely individual variable, dependent on body weight, body shape, and preferred sleep position, rather than a single universal recommendation applicable to everyone, which is part of why extensive in-store testing or trial periods have become such a standard part of modern mattress shopping. A useful general principle many sleep specialists offer, while stressing it as a starting guideline rather than a strict rule, is that side sleepers often benefit from a moderately soft to medium mattress that allows the shoulder and hip enough give to keep the spine level. Back sleepers often do well with a medium to medium firm surface that supports the lower back's natural curve without allowing the hips to sink too deeply, and stomach sleepers, given the postural challenges already discussed, generally fare best with a firmer surface that prevents the midsection from sinking and further exaggerating the lower back's arch throughout the night. Beyond the mattress and pillow themselves, physical therapists also point to a broader category of daytime habits that quietly interact with nighttime spinal alignment in ways many people never connect. Prolonged sitting throughout the day, particularly with poor posture at a desk, can leave certain muscle groups chronically shortened or tightened by the time a person goes to bed, which can then pull the spine subtly out of its ideal neutral alignment even when the pillow and mattress setup itself is genuinely appropriate. This is part of why physical therapists treating persistent morning back or neck pain often ask detailed questions about daytime posture and activity level alongside nighttime sleep setup, since addressing only the sleep environment while ignoring cumulative daytime strain frequently produces incomplete relief, whereas a combined approach addressing both tends to resolve stubborn morning stiffness far more reliably than either adjustment attempted entirely on its own. If you have ever assumed you sleep in essentially one fixed position all night, sleep researchers studying overnight movement patterns using video monitoring and motion sensors would gently correct that assumption. The average adult repositions their body somewhere between 10 and 40 times over a full night's sleep, ranging from small, subtle shifts of a shoulder or a leg to complete, full-body rolls from one side to the other, almost none of which the sleeper remembers upon waking, since most repositioning occurs during lighter stages of sleep or brief, unconscious microarousals too fleeting to register as actual waking. Far from being a sign of restless or poor quality sleep, this repositioning appears to serve a genuinely important physiological function. Prolonged, unchanging pressure on any single area of the body for many consecutive hours can gradually reduce blood flow to compressed tissue, a phenomenon well documented in hospital settings where immobile patients require regular repositioning by nursing staff specifically to prevent painful and potentially serious pressure sores from developing. Healthy sleepers accomplish essentially the same protective function automatically and unconsciously, redistributing pressure across different parts of the body throughout the night without ever needing to consciously plan or remember doing so. Interestingly, sleep researchers have found that the frequency and pattern of overnight repositioning tends to change in predictable ways across different sleep stages, with movement occurring more frequently during lighter non-REM sleep and dropping to near stillness during deep slow-wave sleep and REM sleep, when the body's major skeletal muscles become naturally paralyzed as part of the mechanism that prevents people from physically acting out their dreams. This means the position you fall asleep in, while worth thinking about deliberately, represents only your starting point for the night rather than a fixed condition you maintain for 8 consecutive hours, which is precisely why sleep specialists studying positional interventions, like those developed for positional sleep apnea, focus on gently discouraging specific problematic positions like flat back sleeping rather than attempting the far less realistic goal of locking a sleeper into one single position for an entire night. This natural repositioning pattern also offers an interesting, if somewhat counterintuitive, window into evaluating sleep quality more broadly. Researchers studying conditions like restless leg syndrome and periodic limb movement disorder have had to carefully distinguish between the normal, protective, health-supporting movement described here and the excessive, disruptive movement associated with genuine sleep disorders, since simply counting overnight movements alone cannot reliably separate the two. The key distinguishing factor researchers rely on is whether movement is accompanied by cortical arousal, meaning brief activation of brainwave patterns associated with lighter sleep or waking, occurring frequently enough to genuinely fragment sleep architecture and prevent adequate time spent in deep, restorative stages. Ordinary protective repositioning, of the kind we've discussed throughout tonight's episode, typically occurs during naturally lighter sleep stages or brief, harmless microarousals that don't meaningfully disrupt overall sleep quality, whereas movement disorders tend to produce far more frequent, more disruptive arousals capable of measurably reducing total deep and REM sleep time across the night, which is precisely the kind of distinction a proper diagnostic sleep study is specifically designed to identify. There is also an important practical distinction sleep clinicians make between mild positional apnea, where positional therapy alone can be genuinely sufficient, and more severe cases where positional intervention should serve as one part of a broader treatment plan rather than a standalone solution. Sleep medicine specialists generally use a specific clinical threshold, examining not just whether apnea events cluster during backsleeping, but whether the overall severity of the condition, measured by how many breathing disruptions occur per hour of sleep, falls within a mild to moderate range even during backsleeping episodes. Patients whose apnea remains severe even in this positional breakdown, or whose overall apnea severity crosses into more serious clinical territory, are typically guided toward more comprehensive treatment, such as a CPAP machine, rather than relying primarily on positional therapy, since undertreating significant sleep apnea carries meaningful long-term cardiovascular and metabolic risks that a partial, position-only solution would not adequately address on its own. Dermatologists have identified a subtler, longer-term consequence of habitual sleep position that has nothing to do with breathing, digestion, or the spine, and everything to do with the skin of the face. When a person sleeps consistently on one side, or consistently face down against a pillow, the same specific areas of facial skin experience repeated, sustained mechanical compression and friction against fabric for several hours every single night, year after year, decade after decade. Over time, dermatologists studying this phenomenon have documented a pattern of asymmetric fine lines and creases, sometimes informally called sleep wrinkles, that tend to form specifically on the side of the face habitually pressed into the pillow, distinct in both pattern and cause from the wrinkles that form primarily due to sun exposure or natural loss of skin elasticity with age. These compression-related creases tend to run perpendicular to the direction of repeated pressure, and dermatologists have noted that patients who consistently favor one particular side while sleeping frequently show a visible asymmetry between the two sides of their face upon close examination, with the habitually compressed side showing more pronounced fine lines than the side that spends less time under nightly pressure. Sleeping on the back, by removing the face entirely from contact with the pillow, is generally considered the most dermatologically favorable position from this specific standpoint, which is part of why some skincare-focused sleep guidance gently encourages back sleeping when other medical considerations, like snoring or positional sleep apnea, don't make that position inadvisable for a particular individual. For the many people whose comfort, breathing, or spinal alignment genuinely depends on side or stomach sleeping, dermatologists generally suggest this as a relatively low-priority cosmetic consideration rather than a reason to override more medically significant positional needs, though satin or silk pillowcases have been shown in some smaller studies to meaningfully reduce the friction responsible for this specific type of compression-related skin creasing compared to standard cotton fabric. Beyond fabric choice, dermatologists have offered a few additional small adjustments worth mentioning for anyone genuinely concerned about this particular consequence of habitual sleep position without wanting to abandon a position that otherwise serves their comfort or medical needs well. Sleeping with the head elevated slightly, whether through a slightly thicker pillow or a wedge, can help reduce overnight facial puffiness and fluid retention around the eyes, a separate but related cosmetic concern often mentioned alongside sleep position creasing in dermatological consultations. Some dermatologists also point out that the total pressure and friction experienced by facial skin depends not only on which side a person favors but on how firmly the face is pressed into the pillow, meaning even committed side sleepers can sometimes reduce cumulative facial pressure simply by choosing a slightly softer, more contouring pillow surface that distributes weight more evenly across a broader area of the cheek and jaw rather than concentrating it into one smaller, more sharply creased contact point. This next fact requires a gentler, more careful tone than most of what we've covered tonight, because it touches on research that matters enormously to expectant parents, and deserves to be shared clearly rather than left to vague, half-remembered advice. Multiple large observational studies conducted over the past decade, including significant research published in the journal Obstetrics and Gynecology and corroborated by subsequent studies in different countries, have found an association between going to sleep on the back during the third trimester of pregnancy and a modestly increased risk of stillbirth, compared to falling asleep on the side. Researchers investigating the underlying mechanism point back to the same Vena Cava compression discussed earlier in tonight's episode, theorizing that reduced blood flow and oxygen delivery to the placenta during extended periods of back sleeping, particularly during the vulnerable final weeks of pregnancy when the fetus is largest and demands are highest, may meaningfully contribute to this elevated risk in a small subset of pregnancies. It's important to add real context and reassurance alongside this finding, exactly as the researchers who conducted these studies have consistently emphasized in their own public communication. Stillbirth remains a rare outcome overall. The observed increase in risk associated with back sleeping is relatively modest in absolute terms, and researchers have specifically noted that what matters most is the position a person falls asleep in, since natural overnight repositioning, the same unconscious movement we discussed earlier, means most people do not remain rigidly on their back for an entire night even if that is where they initially settle. Because of this research, major medical organizations including the American College of Obstetricians and Gynecologists now include guidance encouraging side sleeping, rather than back sleeping, as pregnancy progresses into its third trimester, framing it not as a source of anxiety but as one simple, low-effort adjustment among the many small, protective choices that make up thoughtful prenatal care. Researchers who have studied this question have also worked to understand exactly which side matters most, and here the evidence offers additional, genuinely reassuring nuance worth sharing. While left-side sleeping is the position most commonly recommended, given its clearer, more established advantages for circulation and vena cava compression discussed earlier in tonight's episode, several of the specific studies examining stillbirth risk have found that either side, left or right, appears associated with meaningfully better outcomes than sleeping flat on the back, meaning the most important, evidence-supported takeaway is simply avoiding extended time on the back during the third trimester, rather than requiring rigid, anxious commitment to the left side specifically above all else. Maternal-fetal medicine specialists consistently emphasize this broader framing in their own patient communication, wanting expectant parents to understand this as a gentle, achievable guideline rather than an exacting standard that, if occasionally missed during a restless night, should become a source of guilt or worry, since the research itself, taken as a whole, points towards side sleeping in general as the protective factor, with the left side offering a modest additional benefit on top of that broader, more important guidance. Returning to the glymphatic system, we opened tonight's episode with, it's worth spending a little more time on why this research has generated such sustained interest among neurologists studying long-term cognitive health, beyond the original 2015 rodent study. Beta-amyloid, the specific protein the glymphatic system helps clear from brain tissue during sleep, is the same protein that accumulates into the sticky plaques considered a defining hallmark of Alzheimer's disease, found in significantly elevated concentrations in the brains of patients with the condition. This connection has led researchers to investigate whether chronic, long-term inefficiency in overnight glymphatic clearance, whether caused by poor sleep quality, insufficient sleep duration, or, as this research suggests, unfavorable sleep position maintained consistently across many years, might represent one contributing factor among the many complex genetic and environmental influences involved in neurodegenerative disease risk. It's essential to be precise and appropriately cautious about what this research does and does not currently demonstrate. The foundational studies establishing position-dependent differences in glymphatic clearance efficiency were conducted in rodent models, and while human neuroimaging studies have since found broadly supportive evidence that glymphatic activity in humans does increase during sleep in ways generally consistent with the rodent findings, researchers have not yet established a definitive, direct causal link proving that a person's habitual sleep position meaningfully changes their individual risk of developing Alzheimer's disease or other forms of dementia later in life. What researchers can say with considerably more confidence is that sleep quality and sufficient sleep duration overall are consistently associated with better long-term cognitive health outcomes across large population studies, and that side sleeping appears, based on the best currently available mechanistic evidence, to support more efficient glymphatic clearance than back or stomach sleeping. This makes side sleeping a reasonable, low-risk, evidence-informed preference for those who find it comfortable, while leaving plenty of room for the more rigorous long-term human research still needed before anyone could responsibly claim that sleep position alone meaningfully determines a person's future cognitive health. This is an area where researchers actively caution against the kind of overreach that sometimes happens when early, genuinely exciting mechanistic findings meet public appetite for simple, actionable health advice. Alzheimer's disease and other forms of dementia involve an extraordinarily complex interplay of genetic risk factors, cardiovascular health, chronic inflammation, lifestyle factors including diet and physical activity, and a range of other influences that researchers are still working to fully untangle, meaning sleep position represents, at most, one small piece within an enormously complicated overall picture rather than any kind of standalone protective measure on its own. What makes the glymphatic research genuinely valuable, even while acknowledging these important limitations, is how it has helped reframe sleep itself within the broader scientific understanding of brain health, moving it from a passive, restful backdrop to cognitive function toward an active, essential maintenance process with measurable physiological consequences, a reframing that has influenced not just position-specific research but broader public health messaging about the importance of adequate sleep duration and quality as a meaningful, evidence-based component of long-term brain health throughout life. For decades before wearable positional therapy devices became widely available, sleep clinics treating positional obstructive sleep apnea relied on a remarkably low-tech, almost charmingly simple intervention that remains genuinely effective and is still recommended by many sleep specialists today. The technique involves sewing a tennis ball, or a similarly firm, rounded object, into a small pocket on the back of a sleep shirt, positioned directly between the shoulder blades. The underlying logic is straightforward and elegant. The moment a sleeping person unconsciously begins to roll onto their back, the tennis ball creates enough physical discomfort against the spine to trigger a brief, partial arousal, prompting the sleeper to shift back onto their side without ever becoming fully, consciously awake or aware that the repositioning occurred. Clinical studies evaluating this technique against more expensive, technologically sophisticated positional alarms and vibrating wearable devices have found the humble tennis ball method to be surprisingly comparable in effectiveness for many patients with mild to moderate positional sleep apnea, successfully reducing the amount of time spent sleeping on the back and correspondingly reducing the frequency of apnea events recorded during sleep studies. Modern positional therapy devices have largely built on this exact same underlying principle using more comfortable and adjustable technology, typically consisting of a small sensor worn around the chest or neck that detects when the wearer has rolled onto their back and responds with a gentle, gradually intensifying vibration, precisely calibrated to be strong enough to prompt repositioning without being disruptive enough to cause full, conscious awakening or meaningfully fragment overall sleep quality. For people who suspect they may be experiencing positional sleep apnea, characterized by snoring or breathing disruptions concentrated primarily while sleeping on the back, sleep specialists generally recommend starting with a proper diagnostic sleep study to confirm the diagnosis and rule out more severe apnea that might require additional treatment, before relying solely on positional interventions. However well supported these particular techniques happen to be in the clinical literature. It's worth noting how the tennis ball technique's simplicity also created an unintended long-term problem that clinicians eventually had to work around, which itself offers an interesting window into how medical devices sometimes evolve. Patients using the original tennis ball method frequently reported that the discomfort driving them off their back would, after several weeks of consistent use, sometimes begin causing new complaints of its own, including bruising or persistent soreness along the spine from nightly contact with a firm object, and some patients found the discomfort intense enough to fragment their sleep more than a purely positional cue ideally should, prompting brief, more complete wake-ups rather than the intended gentle, mostly unconscious repositioning. This unintended side effect helped motivate the development of modern vibrating positional devices specifically, since engineers recognized that a mild vibration could be precisely calibrated to interrupt back sleeping without the same risk of physical soreness that a fixed, unforgiving object pressed against the spine for months at a time could eventually produce, representing a genuinely useful case study in how patient feedback on an older, simpler intervention directly shaped the design priorities behind its more sophisticated modern replacement. We close tonight with the practical question many listeners are likely holding by now: if your current sleep position isn't serving your body particularly well, how does a person actually go about changing something as deeply ingrained and unconscious as sleep posture, developed over literal decades of repetition since early childhood? Sleep specialists who work with patients on positional changes consistently emphasize that this kind of shift needs to happen gradually and with realistic expectations, since attempting to force an entirely new sleep position through willpower alone typically fails, precisely because the position you fall asleep in matters far less than the position your body unconsciously returns to throughout the night once genuine sleep, and the accompanying loss of conscious control, has taken over. The most consistently recommended starting strategy involves simply beginning each night in the target position, allowing natural, unconscious repositioning to happen as it will throughout the rest of the night, while using supportive tools, like a firm pillow wedged behind the back to physically discourage rolling fully onto it, or a slightly larger body pillow to hug while side sleeping, which both improves comfort in the new position and provides a physical barrier, making the old, habitual position slightly less accessible to unconsciously drift back into. Sleep specialists also emphasize patience with this process, noting that meaningful, durable shifts in habitual sleep position often take several weeks to consolidate, since the body is essentially being asked to build an entirely new set of unconscious motor patterns to replace ones reinforced by literally thousands of previous nights. It's worth ending tonight's exploration with an important, grounding reminder: for most healthy adults without a specific diagnosed condition like GERD, positional sleep apnea, or pregnancy-related circulatory concerns, no single sleep position is objectively, universally correct for every single person, and comfort, uninterrupted sleep continuity, and genuine restfulness remain valid, meaningful priorities in their own right. Tonight's facts are best understood not as a rigid set of rules demanding immediate correction, but as a quiet invitation to notice, with gentle curiosity rather than anxiety, how your own body has been resting all along, and to make small, sustainable adjustments only where your own specific circumstances genuinely call for them. There is one final, practical piece of guidance sleep specialists often add for anyone genuinely motivated to change a long-held sleep position for a real medical reason rather than simple curiosity, and it involves timing the effort thoughtfully rather than attempting it during an already stressful or poorly rested period of life. Behavioral sleep specialists note that attempting to learn a new sleep position tends to go considerably better when a person is not simultaneously fighting other sleep disruptions, whether from travel, illness, high stress, or an inconsistent sleep schedule, since the additional cognitive and physical effort involved in maintaining an unfamiliar position is best introduced when the rest of a person's sleep foundation is already reasonably stable. Choosing a calm, ordinary stretch of weeks, rather than the night before an important deadline or during a particularly demanding period, tends to produce better, more lasting results, precisely because the goal is to build a genuinely new unconscious habit rather than to white-knuckle through a single uncomfortable night through sheer determination alone. A distinction that applies just as usefully to sleep position as it does to nearly every other lasting behavioral change worth making. Tonight we travel through something so ordinary it rarely earns a second thought, the simple, unconscious choice your body makes the moment consciousness lets go each night. We looked at how side sleeping appears to support your brain's own overnight cleaning system, why the left side in particular carries specific advantages during pregnancy and for easing acid reflux, and why lying flat on the back can quietly work against an open airway for those prone to snoring or sleep apnea. We considered the trade-offs hidden inside stomach sleeping, the surprising psychology behind the fetal position's worldwide popularity, and the quiet, constant work your spine performs every night whether you're aware of it or not. We learned that you are moving far more than you remember, protecting your own tissue through instinctive, unconscious repositioning, and we looked honestly and carefully at research on pregnancy, sleep position, and safety that deserved to be shared with real care rather than left unspoken. We even uncovered how something as small and old-fashioned as a tennis ball sewn into the back of a shirt has quietly helped patients for decades, long before more modern devices arrived to do essentially the same simple job. None of tonight's facts were meant to make you anxious about how you're lying right now. They were meant to hand you something gentler and more useful, genuine understanding, offered without judgment, about a part of your own life you've been living through, unconsciously, every single night since before you can even remember. If tonight's journey was worth your time, a like, a subscribe, or a thought left below helps the Sleep Lab stay open for the next curious, sleepy mind who finds their way here. And if you're still awake, there's another story waiting just beyond this one, whenever you're ready for it. There is one last thought worth sitting with as tonight's episode draws to a close. Nearly everything we covered tonight was already happening inside your body long before you understood any of the science behind it, and will keep happening tonight regardless of what you now know. Your spine will still hold its curve, your glymphatic system will still perform its quiet overnight cleaning, your body will still shift and resettle itself dozens of times before morning, all without needing your conscious permission or supervision. That is, in its own way, one of the more comforting truths tucked inside tonight's exploration. You do not need to consciously manage every mechanism we discussed. You only needed to understand them a little better, so that the small, deliberate choices genuinely worth making, a properly sized pillow, a gentler position for a sensitive stomach, a side rather than a back during a particular season of life, can be made with real understanding behind them, rather than blind habit alone. But for now, let your body settle into whatever position feels most natural tonight. Let your breathing slow. Let your thoughts grow soft and quiet. Sleep well. And good night.